Thank you. Assalamu alaikum, everyone. Welcome. Good morning, good afternoon, good evening, everyone, depending on where you are joining us today. On behalf of SIVU, it is my webinar series. It is my pleasure to welcome you all to today's webinar, which you can see the title Tips and Tricks of Debriefing in Healthcare Simulation. And debriefing has been often described as an heart and soul of simulation based education. And who else could be the best one to talk about debriefing? An expert, an accomplished educator, Dr. Professor Anuja Bhargava. She's a professor and head of the Department of ENT at Era University, Lucknow, assistant registrar, academics, head of the bioethic unit, clinical skill laboratory in charge, curriculum committee member, and interprofessional education ambassador. She have many stars to her name. She's a MAHE Famer Fellow, she's also a certified healthcare simulation educator by the Society for Simulation in Healthcare. She has contributed extensively to health profession education through curriculum development, faculty development, interprofessional education, simulation based education, and scholarly work with more than 25 publications and book chapter that may have increased as this may be a little while ago. And today's session, Anuja is going to explore practical approaches to conducting effective debriefing, selecting appropriate debriefing methods, facilitating reflective conversation, and also some housekeeping. Please feel free to participate in the discussion, post your question in the chat throughout the session, and we will reserve dedicated time at the end for bringing those questions and discussion point. It is now my pleasure to hand over the virtual floor to Dr. Professor Anuja Bhargava. And once again, thank you for joining. Over to you, Anuja.
Thank you so much, Jabeen, and a very warm welcome to all our participants. And as Jabeen rightly said, good morning, good afternoon, good evening, and welcome with a lot of greetings. I would take this opportunity to first of all thank the entire organizing committee of SIVU for giving us this chance to share the heart and soul of simulation. Thank you very much, Sakina, for always being there at behind our back, always holding us before we take on to the webinar. So, friends, before we begin with this, as you see, I have put up a picture there, and that picture says that it is what you perform in a clinical scenario is actually pre-decided by what you have been trained with. You can call it a memory, you can call it a frame, but I think at the spurt of a moment, you would act with what you have thought. So, this webinar talks about the tips and tricks for debriefing in healthcare simulation. Now, when we talk about the learning objectives and we move in debriefing, it is important to understand the definition of debriefing, to understand what is the importance of debriefing by having a structured reflection, what are the different methods and how you can apply it to your clinical environment, and most importantly, by executing debriefing, what do we get? Many of us here could be FAMR fellows. Many of us could be aspiring FAMR fellows. One of the fantastic lines in FAMR training that we are told is, what is in it for me? By doing debriefing, what do I get? So I'll stop here and ask Jabeen, who's one of the fantastic healthcare leaders in debriefing, even getting on to making the guidelines for NASCL in debriefing. Jabeen, what do you think debriefing has led you to?
Thanks, Anuja. Debriefing for me is in-depth understanding into the learner's action because as you are postulating some quotes, one of my mentors said that during to the learners when I was a learner that I can see what you are doing, I can hear what you are seeing, but I cannot know what is going on in your mind. So for me, the debriefing is to explore their mental frame, that what was the why behind their action, why they did what they did is kind of a summary why debriefing is important for me and what I get from it.
Thank you, Jabeen, for summing it up for us. That means when you are debriefing, I call it delving into somebody else's mind. You have to actually see through your learner. So let's get on with the journey. When you come to understand, I think if you ask me why debriefing is important for me, we have 17th September coming, and that's the World Patient Safety Day. I think if you look at SIM for me, SIM has been a bridge between my clinical activities, improving my clinical activities with the help of SIM, and improving patient safety. Are we not talking about just the patient? I would like all of you to put in the chat, with Jabeen helping me, why do you think, what is SIM for you? For me, for example, if you ask me what SIM is for me, I'll say passion. But why is it my passion? I grew up to be a doctor. I grew up to take clinical care. Jabeen is a pediatrician. I'm an ENT surgeon. But day in and day out, after years of practice, we realize there is a clinical gap. We can improve. And to get onto that improvement, day in and day out, you have SIM. But within the structure of SIM, the most important bridge that you have, friends, is debriefing. This is one of my favorite slides, which I put in each of my presentation. It sums up simulation for me. What is simulation? I think I was trained in an environment which was absolutely clinical. In the way back in 1996, when I entered medical school, we didn't think about SIM. We didn't think about SIM because we didn't realize we would come to a point where we would need to have many, many medical graduates with the increasing number of people on earth. Now, to train these medical graduates, you would need a way which gives them psychological safety, safe learning environment, and creating exactly what they are doing in the clinical field, which means, which I had mentioned exactly a year back, I need to recreate a minor OT. I need to recreate a triage room. For that, I would talk about using different modalities. I would be using maybe, which I would go on to fidelity, which I had stressed last time. When you talk about realism, which I tell all my colleagues, realism is how real you are able to make the clinical environment for them to believe that they are in a clinical activity and not doing SIM. For that, you can have different ways. You can have mannequins. You can have a standardized patient. You could be using different kind of, I would say, fidelity in terms of equipment, environment for them to create. Now, the fantastic word, which I think is the most important point, the fulcrum, if you ask me, of debriefing, is psychological safety. I would pause here and I would put again, Jabeen, I would help, please need help to put everybody in the chat box. My question is, friends, when did you feel safe? I ask this question in many of my sessions, it's very close to my heart. I felt safe when I held my father's hand. I never forget that feeling ever. That's what safety is for me. And that's the safety which I want to give to each of my learner. As I move on with the slides, friends, try to close your eyes and imagine the moment when you felt safe. It could be anything. It could be with a parent, a friend, and that's not only when you were learning, it could be in your day to day activity. Please put on the chat because I want you all to be in the realism of psychological safety, because that is the emotion which you have to create for your learners in the sim zone. Now, as we move on, we understand we have to carry out a sim activity. We would need some requirements. We would require a sim lab. It has a structured methodology. We define the needs. We do the learning objectives. We do the pre briefing. We do the sim. We do the scenario. But what after that? It could be different. There could be something which you have not asked the learners. You carried out the scenario, you gave them the cues, you gave them the fantastic requirements of high fidelity simulation. But do you think they would be able to perform in the clinical environment? Are you sure about that? So, what is the way to be sure? The best way to be sure is you move on to the zone of debriefing. Debriefing is nothing in three words, if I put it. It is a facilitated, reflective discussion. You are trying to actually replay the simulation experience, but this experience need to be created. You have to create it by doing an effective debriefing, and we see how we do it. Now, what would be the goal? I would stop here again. I would want one of you to maybe come on with the chat, maybe raise your hands and put it in the chat box if you want. What do you think is the goal? To me, goal of debriefing, I think, would be to help myself translate the experience of sim into the clinical activity. Jabeen, I would like to ask you, what do you think the goal of debriefing should be?
As you have mentioned, it's a reflective dialogue, but then that reflective dialogue should have a critical thinking and linkages with the clinical environment, because the ultimate goal is what the learning happened in the sim session will be ultimately translated to the patient care. And the ultimate goal is improvement in the quality of care and improving the safety of the patient.
Fantastic. Do we have some points in the chat box, Jabeen? Do we have anything there?
Yeah, Yogesh has
So,
mentioned that rules are followed. When rules are followed, then the safety comes up, like when you follow, and the debriefing allows dynamic decision making. Then Elizabeth has put deep dive into what just happened and what we can learn from it. Thanks, Yogesh. And then there is some when I have an expert consultation supporting my decision, when I'm a health provider, and when I will be treated by more than one expert. And Muna is mentioning that debriefing is an opportunity where we can discuss what went well and what are the areas that need improvement so that how a learner can improve its performance. So these are some of the thoughts which are there in the chat.
thanks, Jabeen. So that means we are absolutely clear. We understand that we need debriefing. We understand how to do debriefing. When we understand it is a reflective practice. But my next question to all of you is it easy to share what you have exactly felt? Imagine yourself, you have finished a session, maybe say about an activity. I would again quote from the ENT practice. There was a patient who came to the emergency with heavy bleed, and there is an outbreak of dengue in the city. So you have a lot of cases coming which are presenting you with nasal bleed. And this scenario, this patient has entered, and you have to manage this patient with anterior nasal bleed. You decide to manage the patient, you stabilize the patient, you pack the patient. And during the debriefing session, I, as the debriefer, am talking to my participants and I ask them, how did you feel? My first point is going to be, is it easy for them to break the barrier of hierarchy? Talk to me. It may be a little difficult. Let me go on to that. Now, this is the reflective cycle. To imagine and to decode the reflective cycle, I have started doing an experiment on myself. And that I think I started transforming as a human being when I started becoming a simulationist. I started carrying out reflective cycle for each of the activity that I do. If you are able to analyze what exactly has happened and you are able to put it into verbatim without having the fear of being judged. And that's exactly where the concept of psychological safety comes. You create an environment as a facilitator where your participant is able to tell you what he or she felt. Now, in my case, my participant probably lost her grandmother due to dengue year back. So she was able to manage the patient who was a simulated patient coming on a wheelchair. She did the anterior nasal packing on the mannequin. She felt she was able to control the bleeding. But when I asked her, how did you feel? Her answer was, She was apprehensive. She was terrified because she had the memories of having lost a family member due to dengue, which happened 2 years back. But she is still carrying the frame. She is still carrying that impression. And friends, that is jeopardizing her clinical response that would be needed in an ER. And that's exactly what you achieve. So when you plan your debriefing and you are holding hands as a mentor to take them across the reflective cycle, you have to give them the opportunity to move from concrete experience to reflective observation. We all know the COP cycle. We all are well versed. We are all health professional leaders here. We know it's concrete experience, observation, abstract conceptualization, and active experimentation. But I'll stop here. How many of you have done it? Is it easy to do that? Let me take you to a scenario where you are in an OT. You have done, say you are doing a particular surgical procedure. You think it did not go too well. Do you have the courage? And when you come out of the OT, you de-scrub. Do you have the courage to reflect on yourself? Do you have the courage to abstract, conceptualize that, yes, I could have held that instrument in that particular manner. I could have raised the flap in that manner, and that would translate to improved clinical practice. Imagine if you over the years are finding it difficult, how would your mentee who is way down you need this help from you? You have to help him in the journey of reflective cycles. So, friends, we move from one block, the definition of debriefing, importance of debriefing, the importance of the reflective cycle embedded in the process of debriefing. And we understand that we have to hold hands for the mentee as he moves in the cycle of reflection. Reflection can be during the procedure, reflection can be after the procedure. You have to help your mentee go through both these particular steps. This is one of the diagrams which I got on, and I would say I did take the help of a couple of AI LLMs to prepare this. And I have tried to put this as I would say an infographic in my minor OT. So I have started telling my residents that as you go on in your day in and day out activity, reflect and you see how your clinical experiences evolved. Debriefing does not only happen in the sim room. Debriefing happens every second with each of us. So this is it. And I found this pillar which I recreated. I think this is the pillar we ultimately want: improved patient safety. How do we get that? With sim activities, with debriefing, the foundation being psychological safety. I feel psychologically safe with Jabeen and Sakina. I know they are behind my back. Even if my laptop shuts down now, I know I would have one of them share this PPT for me, even cover up for me. And that is psychological safety. You, as the mentor, have to give them the environment where they feel safe, where they feel safe enough to tell you what they have felt. Now, this is one of the next pillar that we come on, that you start to do debriefing. Now, one of my young colleagues walked up to me saying that, ma'am, I'm fascinated by debriefing. What should I do? I said, nothing. What would you imagine your debriefer to do for you? So, if you ask me what my ideal debriefer would be, it's rather simple. I have, I think, been blessed by the best of mentors, which I would really acknowledge at the end of the presentation. I just have to imagine either of them. So, what are they? They are organized. A. B. They always talk to me in a particular environment. C. They always ask me for my opinion. D. They make sure that I am supported from to carry out the particular activity. And that's exactly how we move. Number one, it has to be planned and a structured process. You cannot have debriefing happening as a random activity. So, what we've started doing is we've started having all of us as a community of practice, which we have developed within our university, which we call as a SIM IPE club. And all these proactive simulationists, they move from one room to the other, trying to talk to the subject matter experts, telling them that the actual sim is very important. But when you devise your activity, it moves from pre briefing to the activity, but whatever time you carry out to train the activity, just multiply it by 2, which means twice the amount of time which you have spent in sim is debriefing. It's not a dictum, friends, but believe me, you enjoy debriefing much more than you enjoy the actual sim. And so do your learners. Always take them to a different space. It doesn't have to leave them the frame of the particular recreated ICU, recreated minor OT, recreated OBG room. It is a different room which has a round table where you are able to converse with them. You have already told them with a disclosure that they are under observation. You could replay it with the help of a video presentation. You could talk to them and help them move through the process of debriefing. Most importantly, a competent facilitator. Well, I've changed this word, friends, and I would call this what I call Zaidi sir. You have to have a special facilitator, somebody who makes it look absolutely outstanding for you. And that I think a caring facilitator. Competent you may be. You may be competent to make learning objectives. You may be competent to carry out the same activity, to train them, to help them practice, to assess them. But to carry out debriefing, friends, you have to be caring, because whatever you carry out in the room of debriefing today will lead them to the clinical activity which they carry out in their clinical areas. It could be the minor OT, OPD, ER, or even that's something like an ICU. Conducive environment, which I think I have mentioned below, that you have to help them change the environment, which helps them change the frame, because they could be carrying a particular frame. It would have not been, for example, when I started, let me give you an example like this. When I started doing my tonsillectomies, which Zedi sir will remember, you have to put a tie at the base of the tonsil. Well, I found it rather difficult. My boss told me it is extremely simple. He was my HOD. He started training me. Well, I didn't. I think I went into a zone where I did not feel very safe. And from that day onwards, friends, you will not believe it's been 20 years. I don't make a tie at the base of the tonsil. Disclosure. I use a cautery to arrest the bleeding, because that frame of 20 years back of the OT is crystal clear in front of me, where my boss is telling me this is exactly how you put the tie. You need to have long fingers to put the tie. But I still feel I can't do it, no matter how good I may be at it. But I know I'm not confident. You have to, over the process of your debriefing activity, make your learner confident. And of course, you need to have a theoretical framework or a method when you carry out your debriefing. Well, this is important, I feel. Uh, Many a times when I started the journey of SIM, I started asking myself, what is the difference between feedback and debriefing? Well, feedback is, I think, unidirectional. Let's take an example where you do feedback or you do debriefing. For example, I've cooked biryani this evening, which I haven't, but all of you are welcome for a nice warm dinner here in India. And this biryani is tasted by my family members. Now, if they're telling me, I ask them, how was it? They're giving me a feedback on that, how well I made the biryani. But when I call about debriefing, it is going to be a discussion between two people. You have to ask them what they felt, how, if they acted in a particular manner, as Jabeen said, why, which I will be coming to. And your feedback could be at the moment, it could be immediately, but debriefing we carry out after the activity. Debriefing and feedback are fundamentally two different activities. Well, the questioning that we do when we do a debriefing activity, we always like to keep it with a Socratic questioning, which I will be coming to one by one. I will be breaking the blocks. The first block, as I said, I repeat again, the definition of debriefing, how debriefing has a foundation of reflection beneath it. The next important point, how you help your learner with reflection. The fourth important point, the different pillars which you need to carry out debriefing. The fifth, why it is different from feedback and what you can do to make it different from feedback. And an important slide, which I emphatically state, debriefing versus feedback. They are absolutely distinct processes. I would skip this slide to come to elevating competence. I feel with debriefing, you move from an unconscious incompetence to an unconscious competent, which means you are moving from the novice to becoming a master. But this happens over process. You carry out a simple activity, for example, carrying out a patient, say, of coming to you with labor, and you think you carried out the same activity, but with the debriefing, repeated activities, you will be entering into the mastering area. The three phases of debriefing, which is absolutely very close to me. Now, when you start debriefing, what is your first question? Well, my first question to anybody in my department, as a team, as a leader, as a learner, is what is your reaction? How did you feel about it? When you meet somebody, when you greet somebody, when you see your patients, when you take care of patients, when you write a wonderful article, what is it that you feel? Well, I feel great about it, or I feel miserable about it. For example, as I told you about putting my tie for tonsillectomy, I still feel miserable about it. Okay. Maybe if I was able to do a debriefing exercise that day in OT, I could be tying a tie now. Okay, I asked my one of my learners, what did you feel about it? Well, he said, I feel terrible about it. I said, okay, why do you feel terrible about it? See, he goes on to tell me, and that is the next step. So we are talking about phases of debriefing. So I would like to pause here and ask something which is not so, I would say, fantastic. What is it, a particular moment which you recall where you felt awful during a clinical teaching? I would like all of you to think for a moment, leave the session of debriefing, and go back to your days when you did your graduation and post graduation. And you will be very fascinated to, actually recall. We remember the awful things more than the happier things. We always remember them. We remember the day we were reprimanded. We remember the day when we were told not to do a particular thing in a manner. Are we using the chat box? Jabeen, are our participants using the chat box?
Yeah, they are mentioning there is not now anything, but Dr. Zedi has mentioned a couple of things that how they are now using unipolar diathermy for tonsillectomy, and Mona is saying whatever you are you mentioned, it is very true. These are the comments, couple of, but nothing more.
Okay, so now this is the next activity. All of you, please take on to the chat box, including Jabeen. When did you feel awful? You all got to know when I felt awful. I felt awful about 20 years back in the minor OT when I was about to put the tie at the base of the tonsil. All of you to please put in the chat box. You will only be able to, I think, go through the process of doing debriefing if you are able to feel debriefing. I feel, can we have some responses, please? It is important because I want to walk the journey of reaction, analysis, and summary with you, and not just read it out from the slides to you. Please write it. You will understand what I'm trying to tell you. You feel something, you still feel it. There was a particular lecture which happened, and one of your colleagues was able to comprehend it perfectly. You couldn't. Or you read a particular chapter with your friend, and both of you went and wrote the same thing, but she was able to score better. You wanted to take a particular branch, but you could not get it. Your friend could get it. Do you still feel that? It's absolutely tangible yet. It could be years down the line. But, friends, this is memory. But the memory which you are giving to your learners during SIM is translating into a clinical action. That's what we are trying to share with you. So, as you move from reaction, you have to help them analyze. Okay, you did feel something, you felt good, you felt awful, you felt excited. Well, there's some of them who feel very excited about it, but you have to tell them, okay, fine, we'll carry out a particular process where we'll talk about each learner, how they did, what they could have done better. Well, that is analysis. And the third is finally summing it up for them and telling them that finally that goes into a clinical translatory activity. Well, I would, why would you think pre-briefing is important for debriefing? Well, I think very much important. Well, we have to acknowledge one very important fact, which is day in, day out in all our newspapers, our reading material. A large group of our learners are the Gen Z. They want everything in a structured manner. They want everything to be told to them because they are mature people, adult learners who understand what they're going to do. For example, if I carry out something as simple as doing an otoscopy for a group of my learners, I have to tell them a week before that, okay, on this particular day, in this particular room, you would be having a sim activity for the skill of otoscopy. These are my learning objectives, and we would be sharing a video with you where you would be seeing the steps of performing the otoscopy and going to this particular room, and preferably even share the video where they would be going and which particular mannequin they would be using, which particular otoscope they would be using, or they would be using your probably your endoscopic images where you would be correlating with it. And finally, when you come to debriefing, that this debriefing would be in this particular room, this is going to be the time. That particular aspect has to be shared with them. Okay, now I'll just stop here. Why do you think carrying out a structured pre-briefing, debriefing, this link helps them? It helps you formulate. It helps you understand the journey which you're able to traverse. Friends, knowing the theories of debriefing, knowing that the way you carry out debriefing definitely gives you a lot of advantage. But to walk on the way as a debriefer, you have to hold hands. You have to experience it yourself. And that's when you will have the tangible results for you. And I think that's, of course, one of the very important part. I have had to evolve myself because I wasn't trained in an environment, but I was trained to become a mentor. I was trained to become, I think, maybe a prof, trained to become a leader, trained to become a teacher. There's a lot of difference between being a teacher and a mentor. So you have to evolve yourself as well as you go on this journey. Now, when we come to the structured methods of debriefing, we've understood where we're going to carry out, why it is important, what should be the duration, what do I get out of it. But what are the different techniques? I think I'll start with this simple one here, and that is plus delta. Plus delta is simple. If you remember, you would have one of your less talkative profs in your college who would just smile at you, would not say much, and say, "Oh, you did this. You could have done that little better, I think. It would have been really great. You did a particular experiment in a biochem lab or a pharma lab, didn't go too well." Says, "Okay, you did well. But yes, this particular step was not the way it's supposed to be, and this could have happened." Even to the extent you went on to say probably the differential diagnosis was not the way it's supposed to be. Yes. So plus delta is one of our methods which one you can start as a debriefer. The advantage is it gets you onto the journey of understanding the reflective cycle before you actually understand what the frames are being developed for the students and how you have to uncover them. This is one of the fundamental slides which I'm totally passionate about. And this is absolute credit to Rodolphe et al., which talks about this is a method which has been developed by the, this is particular coming up, which says debriefing with good judgment. Jenny talks about it. And now I have tried this good judgment and I think going with a bad judgment as well. When you're talking to somebody, and you presume your own notions about that particular person, that particular activity, I think you have moved away from good judgment. You have to have an observational method. You have to have a way where you are able to understand what the other person is thinking. You have to help him come up with that. And you have to give your own opinion for that particular activity. You have to give him an absolute environment of psychological safety, which means making it absolutely simple. Debriefing with good judgment would mean debriefing with psychological safety. It would mean debriefing where you uncover frames. It would mean where you ask open-ended question. It would mean where you're able to uncover the reflective cycle. It would mean where you take them from the actual experience to reflection. Now, this is a particular slide which I summed it up. And these are different methods. Well, giving a disclaimer, I've not used any of the methods. Most commonly, when I carry out an interprofessional debriefing exercise, I usually use the plus delta method because I have a group of debriefers. When you carry out interprofessional debriefing, it has to be by your entire group of interprofessional debriefers. But generally, when I carry out an activity which is to my subject, otorhinolaryngology, I like to use the advocacy inquiry method, which is with the credit of Jenny et al. And most importantly, what they have done for the methods of debriefing is they have put it into three-phase and multi-phase models. I would say, friends, you don't have to adapt yourself to the model. I would say you use the model, imply, and ask yourself, what are you most comfortable in? So, for example, you can have a method where you can say reaction, gather phase, you can have analysis, summary, you can have you can have 3D models where you can talk about that. In the multi-phase models, you can have something like debriefing for meaningful learning or after action review. There are multi-phase steps, but at the end of it, you are carrying out reaction, analysis, and summary. I never debrief by using a particular model. What I keep as a fundamental pillar for myself is A, psychological safety for me and my team of debriefers, psychological safety for my learners. I keep the four pillars of debriefing in mind. I keep my advocacy inquiry in mind, and I keep my debriefing with good judgment in mind. That's exactly what I carry out. Well, the advantages of debriefing, I don't think we need to list them. I think you have a better sim experience, you are more confident, you would be able to translate it into a better clinical experience. Not only that, you know exactly where you have gone wrong, you can improve upon it. I think ultimately you go to an environment where there is better clinical environment, more patient safety. So now when I go to practice, that is something which we started doing way back. I started asking myself, am I not a good doctor? Well, I thought I was. I have the accolades, but I felt no, I need to do more. And if I have to do more and have to do more in the same world, I have to make sure that my same experiences are translated into actual tangible experiences. So, as we move on to this particular slide, which I think is extremely important, is you talk about SIM, you talk about doing it with a safe container that is with psychological safety, driven by a facilitator, executing advocacy inquiry, and then finally a conscious competence, a change in behavior. Friends, for example, if you are doing a SIM activity for doing something like, say, suppose a CPR, fantastic. The particular learner is able to carry out CPR by the checklist, one to one. But if his or her colleagues collapses during a lecture, will she be able to resuscitate? Will she be able to perform CPR as well as she performed it for you in the sim lab? Is the question. And that particular bridge, that particular gap is completed by your activity of debriefing. Now, your role as a debriefer, you know, you have mastered your methods, you are using the power of reflection, you know that the sim experience will translate into improved clinical practice. And it gives you a sense of confidence, it gives you a sense of empowerment to go on do better. So you improve healthcare environments. This is one of the particular slides which we used where you can use this. You can empower people, you can use infographics and have it around. Because I don't know why I would ask all of you, I don't know, it's something we all have to understand, because if you go to clinicians, you go to subject matter experts, for example, even for me, if you go and ask me, and you tell me to invest more time in sim, the first question I'm going to ask you as a maybe a sim instructor, what do I get out of it? So you need to tell them that by doing sim, you are actually going to improve patient care. When you are able to show them and identify the gaps, you are able to tell them they need sim, not only for students, undergrads, postgrads, interns, even clinicians, day in and day out, I think should be a part of the sim lab activities. Well, so we got on to this, something which all farmers love, and we love to be change agents. So I asked one of my mentors, well, I'll share my journey with them, with all of you. I fondly share that. What are you? You're a change agent. So within the ENT practice, we decided to do that. This is a brief summary of some 5 years for the journey that we did. We started off with doing sim at the level of interns, where we started training them for being part, actually not even interns, lower down, maybe around third year within the Indian medical system, we have a system where they opt for electives. So we gave them a concept of developing an elective module based on SIM for all ENT emergencies. We devised a module, it's an interprofessional module. We carried it out and it was performed. We saw the results. And this third year student went on to become an intern 2 years later. We developed the next layer. For the interns, we developed another system where we had the direct observation of procedural skills for these ENT skills, emergencies, which they had become more competent. They still haven't become a master. And at the end of internship, when they are graduating, and I find my intern now being able to do, I think, an anterior nasal packing, ear suctioning, maybe all ENT emergencies with the same confidence as a postgraduate first year, it gives me a sense of, what should I say? Maybe a sense of accomplishment, a sense of thankfulness to Almighty for having had this translated. And this effect came when we did it with a structured method. We had what were the objectives. We first went on to do a need assessment. We knew that ENT emergencies should be catered by not only the ENT residents but even the interns. Why? Let me put this to you, because if I have, say, 5 postgraduates, I have 5 postgraduates multiplied by 3, 15 ENT postgraduates. But at the same time, I have 7 intern residents posted with me. Now my team is 21. Plus my 4 senior or 5 senior residents, I have 30 residents. If I have a particular case of road traffic accident coming into my hospital with a mass casualty, I have to have a team prepared to deal with something as simple as nasal packing. And for that, we prepared it with layering, with the need assessment, learning objectives, pre-briefing, activity, debriefing. Debriefing was the most important pillar, because when we took the reflections from our residents, our interns, they told us that out of the sim activity, it was only the activity of debriefing which gave them the confidence to translate this particular sim activity into the actual clinical activity. The third part, which is the tracheostomy activity, which we took up as a part of our farmer projects, was an interprofessional activity constituting the ENT residents. We had allied students, we had the technicians, physiotherapists, and the nursing group who went on to develop a module of interprofessional collaborative practice module for tracheostomy. But we did not stop there. We went on to make it as a part of the institutional curriculum. We did not stop there either. We went on to extend it to carry out interprofessional debriefing. We did not stop there. We made it a part for a scholarly activity where we could share it with many more people and develop a community of practice of SIM advocates believing in debriefing. So this is one of the experience that we had. I shared here interprofessional approach to clinical skills for ENT emergencies, which was an elective module. This was presented as a part of ERA University presentation at the National Conference of Health Professional Educators. This was the particular activity which we've shown. So this is the minority. Friends, I would tell you, I think Jabeen will agree with me. And I think the best of centers, I think what makes a simulationist different from anybody else, you're an innovator. You have to learn to innovate. So we innovated, making one of our chambers as becoming a minor OT, and we have shown this particular slides before as well. We see a use a little bit of mileage, and this entire mileage concept and innovation, I asked the students to give it to me so that they felt more empowered to be a part of the activity. This too was translated into a scholarly activity and presented at another conference the next year at the National Conference of Health Professions Educators. And this is about our tracheostomy care. But friends, it did not stop there. God was great. When we were doing the interprofessional collaborative practice module, it was a time of COVID. And this particular group who was getting trained to carry out tracheostomy with an interprofessional background were the people who were posted to take care of patients in the ICU. And those were people who were COVID patients. And it was only because of the help of debriefing during the module that they were able to translate it into improved clinical practice. This was the particular module that we've talked about. That article that we see on the right hand side is the article which was published in the Indian Journal of Otolaryngologist, which was published. And this article was chosen to be published in an ENT journal. We on purpose decided not to go for a health profession journal or a simulation journal because we wanted to share this with the group of ENT surgeons how to evolve in ENT practice with an interprofessional collaborative approach. This, after being a part of the institutional curriculum for almost 4 years, was published again as a stepladder approach for effective curriculum implementation of interprofessional collaborative practice skills module. And I think the entire ethos of this particular journey, I would put it, is because of the practice of debriefing. We have now people who started off as third year graduates, becoming interns, becoming postgraduates, and even faculty members. They've come up to the level of faculty where they truly believe in the concept of SIM, concept of debriefing, because they have seen tangible improvement. We have an audit where the tracheostomy is performed over the last 2 years with an interprofessional collaborative practice approach. Patients were decanalized. There were less peroperative complications. There were less post-operative complications, which means debriefing translates into tangible clinical outcomes. And of course, it translates into interprofessional collaborative practice, which I am absolutely very, very passionate about. I think with, from, and about each other, without this particular concept, you cannot make the maximum use of SIM. The best way to deliver SIM IPE is only by carrying out this particular SIM activities in a structured manner, which we have talked. And what do we get out of it? Definitely, you get a team which is enhanced preparation for clinical practice, which has two important pillars holding it. Now you have a group of people who are trainees who then go on to become expert clinicians who have know how to practice in a clinical environment with interprofessional collaborative practice with the foundation of debriefing, psychological safety, and safe learning environment. Friends, it's interesting. When I started seeing patients after becoming a simulationist, I became more patient. I became a better, I would say, somebody could hear more. I could be able to relate to them more. So not only does your learner evolve in the journey of SIM, you too evolve. And remember, the most important word for each of us today is only care. Care for your patients, care for each other, be nice to each other. Teamwork, communication, improved IPC skills all lead to increased patient safety. You have a better clinical environment. But of course, you have barriers, which is one thing which you see here. Well, I think the simulationist sees no barrier. For me, if you ask me, every challenge is translated into an opportunity. We will motivate people. We will have people who are proactive within your own ecosystem, friends. You would have challenges. We all have challenges. especially carrying out same IPE. I think we are from different professions. We have lack of time. We have different schedules. We could be working in different time zones also. But if you are motivated, you have decided for a particular passion, you have to find the stakeholders who are passionate. You have to get that. You have to have people. There could be at the level of learners who would again find themselves, again, I would say the Gen Z says we are overwhelmed by a particular activity. You have to tell them how important it is for them, and you have to show them the tangible results where they understand, yes, this should be a part of their curriculum. Not only that, right at the bottom, you know, you have your organizational level, which could be a barrier for you. So one of your stakeholders for carrying out a successful sim, carrying out a successful sim IP, carrying out debriefing, you have to have your organization with you in totality. And of course, as I always conclude my presentation, I hear and I forget, I see and I remember, I do and I understand. I don't only understand a clinical work, I understand people. I help people to translate and become improved and better caring human beings. And I think in the process, you become better clinicians. And with that, this is an era and a Sivu presentation. We thank Sivu for this opportunity with wholehearted acknowledgements to Zaidi sir, to Dr. Farzana Mehndi ma'am, my honorable Pro Vice Chancellor ma'am, who is my mentor and has been with me all through and is actually, I give all the credits which I have only to ma'am for having me here, Dr. Sucheta Dandekar ma'am, Dr. Nirmala Regge ma'am, and all my friends which I call in the Department of ENT Medical Education, my dear friends Jabeen and Sakina. Thank you very much, ladies. Thank you very much, friends. And that is for today evening. The house is open for questions.
Thank you, Anuja. I will open the floor for any questions, comments, um, and anything that anybody want to add on to a very comprehensive presentation that Anuja has given. Prof. Seti, do you want to say something? Meanwhile, people are thinking about or writing in the chat.
Well, I'm always very impressed with both of you. Anuja has an excellent in presentation, the flow of thought, as if she has been practicing for years, and obviously she's been practicing, like she said, about 20 years. Flow of thought, comprehension, presentation, and a focused talk, always focused, always focused. It's the ultimate message, loud and clear. And I couldn't agree more with that. Simulation is really important for not only surgical skill, but also in medical skill, even in daily life. I mean, simulation is what is needed now. You have to understand things before you actually apply in practice. There was a time when I was trained many years ago that see one, do one, teach one, but that's gone. You have to learn, and you have to learn. Otherwise, you end up with problems, litigation, medical legal issues, ethical issues. That is one of the reasons why clinical teaching has changed over the years. I mean, the old-fashioned ward rounds where you used to talk to a patient or about a patient in the whole crowd. And that's all gone. Simulation is the art that we have to assimilate, understand, comprehend, and apply. Congratulations, Anuja. Thank you so much for coming over and telling us more about it. And thank you, Jabeen.
Thank you,
Thank
Prof.
you so much, sir.
Seti. Yeah, and then for all the participants, you're putting your name in the chat. I would highly encourage you. There's a link of a Google form. Please open that up and put your name and email there because I don't think so. It is convenient for us all to get everybody's name from the chat. So please do that effort so that your names are correct on your certificate. Thank you. I appreciate that. With that, I see a lot of familiar faces. I Sometime I like to call their names, but it is not to put them on spot. But maybe Dr. Mona, Dr. Abdul Razak, Yugesh was very active in the chat. If you have any thoughts from you want to share your experience about debriefing, or if you have any other comment, please let me know. There is one question, Anuja, by Elizabeth. This is she's praising about your presentation. So, what about debriefing professionalism challenge? Can it be done in a group? This is the question she has put in the chat.
Yeah, thank you, Jabeen. And I would take that question. Thank you, Elizabeth. Thank you very much. Well, I like to tell you, as mentioned, you have to develop a group of people who are proactive. And this group of people within which is who are group who is proactive will ultimately be leading your team where you carry out debriefing in a group. Now, when you carry out debriefing in a group, if it is uni-professional, it will be from within your own department. But if you carry out debriefing for an activity which is interprofessional, so it will be a group of people who are from different departments, or they could be from different streams for that matter. For example, if you're looking at, say, a medical university, so you would have people from the nursing curriculum, you would have people from the allied curriculum. And interestingly, within the Indian subcontinent, there has been a lot of change, not only in the medical curriculum moving towards CBE, the nursing curriculum, the allied curriculum. Now, the entire country is moving towards improved patient practice, improved patient safety, which you can only achieve by doing an activity with an interprofessional group. Now, the point is, which I still have not answered, how to get these people together. You within your group, you have to carry out small activities. What I just mentioned, we have a sim IP club where we meet time to time, maybe once in a month, and we try to understand these hurdles where we could face. It could be a time challenge, it could be lack of motivation, it could be other factors, and it could be most importantly trying to align our learning objectives. Learning objectives for a postgraduate ENT resident, for an allied final year nursing curriculum will be different, which you have to, I would say, crash out as a focus group discussion within your own self. So you are a team within the team. So you actually carry out sim within your own self before you actually go on to carry out the sim activity. That's the way out.
Yeah, and my comment was just to take forward what Anuja has just mentioned. If it is, it all depend what kind of professionalism issue is. I would really focus on the team performance, team behaviors, rather than commenting on individual performance in a group of people. And I will try to address a personal gap as a gap which group can learn from. So taking from me to the whole group, like for example, if I have done something wrong, and if you really feel that there is a only one person issue, because Anuja will agree with me, it's very, very rare that a communication, leadership, professionalism issue happen just because of one person. It usually there are multiple factors that contribute to it. So it's better to explore those factors. But if you feel like that professionalism is a single person fault, which is very, very less likely. So then there are certain other ways to mitigate that. But I would highly encourage in debriefing, in groups, focusing on the group performance and group behaviors. Mubashir is asking Anuja, so to reach a level of real life practice for simulation of an ENT procedure, how many times it has to be practiced? Very interesting
Thank,
question. Let's see how would you approach it.
Thank you, sir. Thank you, sir. Fantastic. Well, I put it to the skill that I'm looking at. For example, I put some skills, for example, something as simple as, I won't say simple. Let's put a few examples. Somebody with all ENT backgrounds would understand otoscopy, anterior nasal packing, posterior nasal packing, going on to do a tracheostomy, and then finally going on to, let's me take the last example of doing a bronchoscopy. So what I did for that is I have actually within our own curriculum, sir, I've divided the postgraduate curriculum into entrustable professional activities, which helps me decide that depending upon, I would say, the skill which is in question actually determines the sessions that will be required. A. So that means it is the skill. For example, if I take otoscopy, sir, otoscopy on a mannequin, then otoscopy with a tympanic membrane which the mannequin has, along with an endoscope and a visualization, and then helping me, having him assist me, observe, and go on, is far less as compared to having him do anterior nasal packing. Because anterior nasal packing needs, I think, has a steeper curve as you move from a novice to an expert. It depends upon the curve. It depends upon the outcome of the skill that I have. For example, sir, if I do an otoscopy, I don't say that it has less complications. But if he puts the speculum wrongly, sir, the patient can collapse because of vasovagal. However, in an anterior nasal packing, if he does it not properly, you can have a fracture of the middle turbinate leading to CSF leak. But let me take you to the journey of bronchoscopy, sir. There would not be even that much time that we would have. Because if I have a patient come in foreign body, my student attempting bronchoscopy, I would lose the patient on table. So it is determined by the steepness of the curve of the skill. And those many times my student does it. So I have a complete method, a chart for each particular skill, number of times which has to be practiced, after which the number of times it is, of course, it is going to be assessed. Then he has to do it being an assistant. Then I have to observe it. And finally, he will do it. And when I am observing it, I'm observing it by using the method of direct observation of procedural skills. Not only that, sir, I will add to this. In the year 2019, December 2019, the National Medical Council gave a set of skills for the MBBS graduate in Indian subcontinent, where they added a suffix of independent, observe, and demonstrate, depending upon the skill. Because, for example, lumbar puncture only goes to the level of observance, but intramuscular injection goes to the level of independence. It is the skill and the importance of that skill in the society. So, for example, my ENT resident who has to know our otoscopy, has to know how to do anterior nasal packing, but he may do bronchoscopy under supervision. I hope I've done justice to the question, Jabeen.
Yeah, Anuja, and I would add this is whole concept of competency-based medical education, deliberate practice, because now it is no more very hard and fast time bound or number bound. It is competency bound, and every learner is a different learner. I may learn the skill in 15 times, and Anuja may learn that skill in 5 times, but there's a minimum number of the time you have done a procedure. But when you become an expert or when you become competent, that is very much variable. So that is also to keep in mind. But yes, as an educator, we should, our simulationists, we should mention or make sure that what is moving them from novice to expert. Last question we take, and then we will close the session. Prof. Muna has asked, did you encounter a junior student who became angry during debriefing? And how do you deal with such a student? I would say a lot of time. But Anuja, do you want to share your strategies that how would you manage those students?
Yeah, I think, well, Mona, thank you for the question. Well, I'll tell you, there have been times when the facilitator is also angry. How to
Yes.
deal with the angry facilitator is also a thing. Many a times we face that, I think so. And Jabeen is smiling. She's taking a sip of coffee with that. Well, you have to take that. It happens, you know. So, well, we all have bad days and good days. And I think the best way to do it is that particular angry mentee is taken into a different room. I chat up. I create perfect psychological safety. And I step down from being a mentor to being a friend. And I tell him, listen, you're also overwhelmed, so am I. And you need to understand that we have to get through this. You're doing medicine, these are your objectives. You're an adult learner. How would you like to do it? There are many times you will face this. But I think the best way to do it is my only answer for everybody is psychological safety. I do it day in and day out. And I have had fantastic experiences. Instead of telling everybody in my department, in my classrooms, I've started asking everybody, what do you feel? What do you want to do? As which is said as a part of advocacy inquiry. You have to see what you have seen, you have to wonder what they're thinking, and finally you have to help them uncover that particular part.
Great. I wish this conversation will continue because this is what me and Anuja are very passionate about, but we are limited by the time. So that's why I'm taking this opportunity to close the session by thanking Prof. Anuja Bhargava for such an insightful and practical session. And today's webinar again reminded us that simulation creates the experience, but the debriefing creates and progress the learning. So that is a point that I am taking away. And at the end, on behalf of Sivu, I would like to express our sincere gratitude to you all, the participant, Sakina, Prof. Zadi, my friend Anuja, for sharing your expertise and experience, and also to all the participants for your active engagement, thoughtful question, and the commitment to advancing healthcare education. Your participation matters the most because that's what we are hoping that by your attendance, you will take it forward, what the learning we are providing or we are sharing with you our experiences. We will hope that you will join us in the future webinars, and we will continue together exploring innovation in healthcare education and simulation. Until we will meet again, stay safe, continue your learning, and remember the point that Anuja has made again and again. The simulation activity ends when the scenario ends, but the learning begins with the debriefing. Thank you, everyone. Have a wonderful
Thank you,
day.
everyone.
Take care.
Thank you.
Bye-bye.
Bye-bye.
Thank you, everyone, for joining. Just a couple of announcements. We have Dr. Komal Atta on August 1st. The topic is When Competence is Not Enough, Trust, Power, and Entrustment in Medical Education. So please save the date. I will be sharing more details. August 1st, 1:30 GMT time. And also, we are going to have a workshop for simulation by our two amazing ladies. So look out for registration, look out for information. With that, I really thank you for joining us, and we will see you in 2 weeks. Thank you.
Thank you,
Bye-bye. Take
everyone.
care. Allah
Bye.
Hafiz. Stay safe.
Allah Hafiz. Bye-bye.
Bye-bye.